Dr. Scott Wright, a professor of medicine and associate editor of the Mayo Clinic Proceedings. Today, it's my great privilege and frankly my honor to introduce and interview Professor Véronique Roger, who's now at the National Institute of Health and for many years was a colleague at Mayo Clinic, and we're quite proud that she's also a Mayo Clinic alumnus. Dr. Roger, welcome.
Thank you so much, Dr. Wright.
Well, Dr. Roger, maybe you could start by telling us a little bit about your early days coming to Mayo. I want to just share with our audience that I believe you were destined to work at Mayo because unless I'm misrecollecting, you were born in Ponte Vedra, Florida, or close to, or spent some time in your early years there, which ultimately is where Mayo decided to locate its Florida campus.
Yes, indeed. Yeah, it is kind of a sign of fate, I guess, for lack of a better word. But I was actually born in Jacksonville, Florida, long before the Mayo Clinic got its site over there. And my mother was a Florida girl and married a Frenchman. And so she then, shortly after I was born, I moved, they moved, and me along with them to Paris, France, where I grew up, where I did all my, undergrad studies and then medical school. And after medical school, when I was kind of in the middle of a residency in France, I always had the sense that I wanted to go and study in the United States. And my father, who was a French dentist, had actually completed a DDS at Northwestern during his course. So he was very much an Americanophile, if there is such a term, and drilled in me that, the United States was the place to be. And so when an opportunity opened up to visit the Mayo Clinic one summer, I was in medical school, I did. And I remember being in the echo lab at that time. This was really the heyday of echocardiography. Jamil Tajik and Jim Seward were running an echo lab unlike any other echo lab in the world. And I spent a month there, lived at the Kaler at that time in the students' room, which, was a different experience for me. And at that time, I was asked what my plans were. And the Mayo Clinic being the Mayo Clinic, I was asked whether I wanted to interview for cardiology fellowship down the road. And I said yes. Because I thought that sounded cool, but I had really no idea what I was saying yes to. I interviewed with some colleagues that we both know well, some of whom are now retired, of course. And I was offered a position as a cardiology trainee a couple of years down the road, which, changed my personal and professional life completely. And so then I joined the cardiology training program, was enthralled with the practice, the scholarly minded clinicians, the dedication to the patient. I mean, the deep sort of embedding of the needs of the patient come first. I mean, it's a slogan, these are words, but at the Mayo Clinic, it's not words on a piece of paper or words in a billboard. I mean, it really is lived. And that was just, I realized that was a place that I wanted to be. So then I was very fortunate to be offered a position to stay on staff. And that's what I was, extremely proud and privileged to be able to do. So.
Oh, that's a wonderful story. Did you spend any time between your fellowship and you coming on staff back in France?
Yeah, it was interesting because I was, I just absolutely loved the practice at Mayo during my fellowship and the training opportunities. And, it was a time of personal growth for me, which was enormous. But I wasn't quite ready to leave France. I grew up in Paris, which is a city unlike any other. I had family. My family was all in France. My parents, who were not getting any younger, and close friends and all that. So I needed to go back. I needed to go back to realize that I could cut the umbilical cord for good, because it was no longer, it was a permanent move. And so I went back, and after about 3 months, I said, okay. I wrote to Dr. Fry at the time, who was the chair of medicine. And I said, Bob, I think I've made up my mind. And so that's how it worked. There was an academic title in France that I wanted to be able to have. And so I had to stay those 2 years to get that. And then I came back.
And as I recall, you had married by that time and came back with your husband. Is that right?
Yes, yes, that's exactly right. My husband is a cardiologist as well. And, we were exceptionally fortunate to have a position for him. And so we came back together.
We were fortunate to have both of you back here for many years, and you made enormous contributions to the scientific literature and to echo as a field. When you came back to Rochester, you worked in the echo lab, I believe, and also did some clinical work. But at one point, you decided to pursue a master's in public health, I believe. Is that right?
Right. And, this was another, Mayo Clinic miracle for me, which is that I worked in the echo lab. I worked clinically, 100% clinical. I did, everything, hospital service, echo lab, outpatient clinic, etc. And I loved every minute of it. But always had a sort of an aspiration to be able to spend more time in research. And I was interested in public health. I was interested in epidemiology. I had done a paper when I was a trainee at Mayo, a fellow at Mayo. I had done a paper with some of the colleagues who were cardiovascular epidemiologists in the Harwood building. And so I thought this was fantastic. And I said, this is great. This is what I really want to do. And so after I came on staff at Mayo, I realized, well, I really would need more training if I want to be able to do this. And so, I kind of started asking around, and then I heard that the University of Minnesota School of Public Health was a premier school of public health in the nation. So I said, okay, that's not too far. And then I started asking more, and then I asked Bob Fry, and he said, well, there is such a thing that's called a Mayo Foundation scholarship. And, maybe you could do that to get your master's in public health. And I said, yeah, that sounds great. And so it was a very, again, a very generous, and I don't mean financially, but it was a very generous gift of Mayo to allow someone who wants to pursue further training, whether it be clinical, by the way. Some people have used this mechanism to learn a technique that wasn't yet at Mayo, or to, pursue some formal epidemiology training, which was my case. And so I did that, for a year. A master's in public health is typically a 2-year program, but I'm really going to date myself here, but this was pre-email, pre-computers, pre-online. And so I was actually driving to Minneapolis to go to class, which, in the Minnesota winters was a little too exciting at times compared to what I would have liked. And so I really managed to try to get it done in 18 months as opposed to 2 years. And then I got my degree, which kind of allowed me to then develop a research career and get grants and, to support my time, et cetera. So.
Wow, that's a firm and strong commitment. And having lived in Minnesota many years as well, the commutes between Minneapolis and Rochester are tough.
Yeah,
and especially when we have blizzards and snowstorms on the highway.
yeah.
For our fellows and younger faculty who might be watching this interview down the road, Veronique, would you mind sharing just how you balanced it all? You had, I think, children by the time you were starting this master's degree, and you had a full-time job and career. And how did you balance it all? That's commendable for any of us, but you did it with poise, and it seemed was no stress at all. How did you do this?
Well, I wouldn't say no stress at all. I think there was well hidden stress probably, but I think I was there were, first of all, again, the Mayo Clinic gives you a Mayo Foundation scholarship, which allows you to take some time. So I was not seeing patients during that time. I mean, it was essentially 12 months where I was not seeing any patients at all. Obviously there were some adjustments and compensation all that, which was expected and beyond fair, actually. So I had that time in terms of hours in the day. And I had a husband but at that time, my husband was 150% supportive. So, when I would leave home, to be in class at 8, to be safe, I would leave home at 5, to get there. And so, my husband was taking care of the kids. And then I had a fantastic childcare provider. She was just exceptional. And, the combination made it feasible. I wouldn't say, from a logistical standpoint, it was challenging, yes, but it made it feasible.
Wow. And then you returned back to the practice, and within just a short time, you were NIH funded for grants, as I recall.
Yes, yeah. Yeah, I think it was, the School of University of Minnesota School of Medicine is exceptional, really, really exceptional. And I worked with terrific mentors over there who, I just learned how to, what's called grantsmanship when you write grant and how to go about it. And my colleagues at Mayo, who are epidemiologists, who at that time worked in the Department of Health Sciences Research, as it was called, were remarkable colleagues as my clinical colleagues were, and so they really helped me, and it enabled me to get started. But I do want to say that I never gave up my clinical practice. As a matter of fact, I've always had a bit of a schizophrenic sort of approach to that, because I did only hospital service, because doing hospital service allowed me to work very hard clinically, of course, as we know, but it was in blocks. And so once you were done, you had some returns to see, but it was not as challenging perhaps as outpatient clinic, where you have more follow-up, et cetera. So I enjoyed every minute of my hospital service. I mean, I think the hospital practice at Mayo Clinic is second to none. I don't practice anymore here. I was offered possibility of practicing, but I figured it's going to be difficult to adjust to a different practice environment. And at this stage in my career, I didn't I was wanted to focus on the research transition, but I miss it. I miss the colleagues on the hospital. I miss the nurse practitioners and physician assistant that were just exceptional people. And I just loved every minute of the patient care there. And it didn't matter whether it was we had to come in at 11 p.m. or 7 a.m. or whatever. So it's and to continue to maintain clinical practice was essential for my research, because by talking to colleagues, it helps you understand an unresolved question, an ambiguity in the data, a reason why we're not so sure we need to do it that way. And so it's really is a propeller for research questions, at least for the research that I do, which is very clinically oriented. So,
Well, yes, and I think one of the one of the key learning points I see here for all of us is that you had organized your work, your clinical work, such that you did it in blocks so that it was highly focused and concentrated. But when you were off hospital service, you didn't have a long tail of clinical follow-up, so you're able to refocus back on research. And then when you did clinical practice, you could enjoy it, and maybe your time allocation was such that you actually enjoyed doing all that you were doing, because you were doing just enough to love what you were doing and not too much that you were tired of it.
Yeah, no, exactly. I mean, I was, the organization, it ended up being, it made sense from a logistical standpoint, but it was very enjoyable. I mean, I really, really liked it. So I was looking forward to come on service. As you probably remember, there was a time period where we were doing 3 weeks, right? And so, and when we went from 3 to 2, and then now to when I left, slightly different system, I kind of like, why are we going down from 3 to 2 weeks? I love the 3 weeks. I love the patient volume, the cases, the interaction with colleagues, and all of that. So yes, I mean, it was logistically logical, so to speak, but it was also very enjoyable.
Yes, yes. Tell us a little bit about what your grants were involved with, what you did research on, and maybe some of the seminal work that you did.
I had the privilege of working with epidemiologists in the Department of Health Sciences Research, and realized that the potential of the Rochester Epidemiology Project, which is now in 27 counties in southeastern Minnesota, as a platform to do epidemiology research. And so because it's a catchment area that includes all the population, because Mayo Clinic and Olmsted Medical Center are the two vastly dominating providers, so we could really capture the entire healthcare experience of these patients in that geographical region. So we had a denominator, which is the population of southeastern Minnesota, and a numerator that was these were the patients who were seen at those facilities. So this was an asset that was absolute. I mean, it's probably close to being unmatched in the world, except in perhaps some Scandinavian countries, et cetera. So this was really the foundation of this work. And we started, I was obviously a cardiologist, so I was interested in cardiovascular disease epidemiology. We had a colleague that Dr. Daniel Connolly, who had done that work and had retired shortly before I came on. And so this line of work of partnership between epidemiologists and cardiologists to study cardiovascular epidemiology was kind of, there was a bit of a hiatus because of the retirement of Dr. Connolly. So a colleague of mine told me, said, well, why don't you do that? I said, yeah, why not? And it was really how it got started. And so we got a few grants to look at trends in cardiovascular disease in Olmsted County. Is it going up? Is it going down? You know, we see patients in cardiology where we try to prevent heart disease, or if it happens, to treat it better. What effect does it have in the population? Are we successful? And so there was really the beginning of a series of questions along those lines. And, you know, some of the key findings perhaps is that we, to our surprise, to my surprise, we identified that the incidence of myocardial infarction was going down in the community. I mean, the heart attacks that I was seeing when I was in training, when, you know, we're in the CCU with thrombolytics back then, and then soon after that PCI, all of a sudden we started counting the number of cases, they were going down. And, you know, of course, you know, it's been attributed in part to statins as a, you know, such a highly sort of prevalent use in the population, as well as, very fortunately, progress with tobacco control. So we saw that, but then we said, well, what's happening to heart failure? And is heart failure, there was some talk about an epidemic of heart failure. So we started looking at that, and we said, well, the incidence or the number of new cases of heart failure is not changing. So it's not going up, but it's not going down either. And the mortality of heart failure is persistently high. And as a matter of fact, as I'm sure, as we all know now, mortality of heart failure is not going down as much as it should in populations. And so these were some of the things that we were able to uncover by studying a population, which is very different than when we practice, where, you know, we see in the hospital the people that typically don't do as well as the ones who are not in the hospital by definition. And so by looking at the population, we could get a sense of what was happening on a broader scale, basically.
Correct my recollection if I'm incorrect, but Olmsted County went through a public health change during your time when we banned smoking from public places, including restaurants and bars.
Yeah.
And am I recalling correctly that you demonstrated that the incidence of acute myocardial infarction fell after the ban? And maybe you could share a little bit more about how you studied that and what your findings were.
Sure. Yeah, no, absolutely. I mean, I think you know, this was a collaboration with Richard Hurt and John Ebert. John Ebert, who is a colleague and a friend who's, to my understanding, still at Mayo Clinic. And so they were both really focused on tobacco research. And, you know, Richard Hurt was very involved in the tobacco ordinances at the state level. And so he came to me one day and said, well, you know, we wonder if this could have an influence on the trends in the incidence of not only myocardial infarction, but also sudden death. And so we were able to look at trends in the population and see that, you know, we saw a decline in sudden death and a decline in the incidence of acute MI. That was sort of timed with the changes in the public policy of smoke, you know, secondhand of public smoking, which led to secondhand smoking for some people. When you could smoke in public, even if you're not a smoker, obviously you were exposed to secondhand smoke. And so we're able to see that it affected not only the smokers, but also the general population, which was a really interesting finding.
Yes, and I believe that was a fairly profound finding, which further supported efforts to ban secondhand smoke exposure in many instances. And so that's one of many seminal observations you made, and really helped advance public health to a great extent. I commend you for that. If I could just ask you, maybe we could pivot on that just for a moment before we go back to sort of your later stage at Mayo. Where do you see if we want to continue to make public health gains in reducing the rates of myocardial infarction and sudden death, where are the frontiers now that we ought to be thinking about public health?
Oh, I think the frontiers are upstream. I mean, and that applies not only to myocardial infarction and heart failure. I think if you look at the burden of risk factors in the US population, in particular obesity and diabetes, you know, this is where the battle should be, because I think the trends in myocardial infarction are favorable right now. We need to make sure that they remain favorable. So that degree of surveillance, that activity of surveillance, if you will, is important. But certainly we know that in heart failure, we're not making the progress that we should make. And I think, it's been interesting that from a policy standpoint, back in, I think it was in the early 2000, but the policy of hospital reimbursement plans were implemented, whereby if patients with heart failure were readmitted within 30 days of a hospital dismissal, there were some financial penalties for the hospital in question. And that program has not resulted in a decline in hospital readmissions, despite an enormous amount of work, as we know, both of us, on the clinical practice to help get these patients on guideline recommended medical therapy, have outpatient management to help them, take their medications. There are multiple measures to combat hospital readmission. It hasn't really been that successful. And mortality, total mortality, hasn't really budged. And so I think this is telling us that, of course, as cardiologists, we need to continue to do what we're doing and do the absolute best possible work to take care of these patients. But if we really want to make a dent in heart failure and heart disease in general at the population level, the battlefield needs to be upstream, and it needs to be, with control of the obesity epidemic, which leads to diabetes, increasing physical activity, continue and even enhance the battle with tobacco. So this is really where we need to put a massive effort, which is tough for us as practicing clinician, because these behavioral health related decisions are not happening in our doctor's office. We can tell people to stop smoking, we tell people they need to exercise, obviously tell people that they need to eat correctly, or follow some diets that have been really demonstrated to be effective. But the daily choices that our patients have to make, we're not there and society needs to be cognizant of this, and try to help all of us, basically. And I think when you see the emphasis currently with ultra processed food and other additives in food, it's really, really important that these battles be fought and that they be successful, it's a tall order with the food industry, of course, but that's one of the critical elements. When we look at what our patients eat, we understand that, this is a big part of the equation.
I wonder if you might care to comment on things that I see gathering a lot of attention, especially at ESC when I attend those congresses annually, and that is emphasis on small particulate matter contributing to early atherosclerosis and acute coronary syndromes and population noise exposure. Where do you see those risk factors, and should those also be public health measures we aim to improve?
Yeah, and I think that actually, I'm glad you asked the question, because I think this is a really important point that, we as cardiologists and primary care providers have focused on the risk factors that we know, right? So we focused on hypertension, which, by the way, should be also part of the major efforts that we should deploy right now. And the American Heart Association is launching a renewed focus on hypertension. But these other risk factors, such as particulate matter exposure, such as even extreme heat, for example, which can trigger cardiovascular events, and other risk factors of that nature, they've been perhaps less studied up to a point than the ones that we know and that we care for in the clinic. And so these are critically important, and they need to be addressed as well. It's another battle that has to be fought outside of the doctor's office and regulated through policy making, which, as you know, of course, is a different kind of battle, I guess.
Well, in your final sort of third of your career at Mayo, you continue to become just more and more successful with grant and funding and publications and impacting public health and mentoring. And then I think one day you got a phone call from someone at NIH. Tell us a little bit about that.
Well, I think I've always been very involved with the American Heart Association throughout my career at Mayo, and then I've also been asked to serve on a variety of National Institutes of Health committees through my career. When you become grant funded, typically people approach you to serve on review grants of your colleagues beyond what is called study section, which is a grant review sort of organization at NIH, and other workshops. And so I gained a lot of familiarity with NIH in general and National Heart, Lung, and Blood Institute, which is my institute, over the years. And so I became aware at some point that they were interested in increasing the number of investigators in the intramural program at NIH, in addition to Framingham, which of course is the other epidemiology enormously prestigious entity within the intramural program at NIH. And so when I heard that this position was open, it was aligned with my professional profile to such a degree that it was pretty difficult not to apply. And so I applied, and I was very fortunate to be offered the position. So
Tell our audience your current role at NIH because it's quite prestigious, and you've been downplaying it, but you are just an incredibly accomplished scientist, and I think the current role is just quite an honor to you for your accomplishments.
yeah, definitely an honor and a privilege. I mean, so what I do, so the NIH has a National Heart, Lung, and Blood Institute has an extramural program, which is the largest proportion of its budget, which consists of grants that you apply to and you get them, and then you do your research. And so I was an extramural investigator at a National Heart, Lung, and Blood Institute for my entire Mayo career, pretty much. But where I am now is in the intramural program. So what is less well known is that there's a much smaller proportion of each institute's budget that is dedicated to support intramural investigators. So you become an employee of NIH, a federal employee, therefore, and you're given resources through your own budget to build a lab, hire individuals to work with you, and develop a research program. And so my current role is what is called branch chief, which, for all practical purposes can be compared to perhaps a division chair. And I was recruited to create a new branch in epidemiology and community health, as we call it, on the Bethesda campus, because the Framingham branch, which is the second one, is at Framingham, Massachusetts, and the one that we have created is on the Bethesda campus. So that's what I do.
Well, Dr. Roger, you've not only had an accomplished and distinguished career as a cardiologist, but also as a public health champion. What advice would you give, younger cardiologists or physicians watching this who maybe aspire to do some of the incredible work that you've done? What would be some nuggets of advice you might like to leave with our audience today?
Well, I think it's. I've been so fortunate, to be able to be at Mayo Clinic, have colleagues at Mayo Clinic who, listen to my aspirations and gave me the means to fulfill them, and all the way up to where I am now. So I think the advice would be first, but I follow the passion. I mean, that's what I wanted to do, and I think knocking on enough doors until somebody behind that door says, yes, I see what you want to do and I'm going to help you because I think it's important, is absolutely critical. And again, I would be completely remiss if I didn't mention Dr. Robert Fry, who was absolutely instrumental in me being able to carry the journey at Mayo Clinic. I mean, Bob was the person who, brought me at Mayo to begin with. And then when I knocked on his door saying, there's this thing called a master's in public health, and he said, okay, let's do it. And, this is really what fate and faith, puts in front of you. And you just have to be that lucky. And so, but, those people are out there. And so, you have to knock on a lot of doors, but you will, more early career people will find these individuals and will be, there are individuals who would give them the opportunity to follow their passion. And then the other thing is that sometimes you have to not need too much sleep. I mean, it is true that sometimes you just have to, agree that, there's going to be a time in your life where you're going to need to dedicate, some time to do this work. But I've never regretted it, and I've always enjoyed it. So, I think it's Bob Fry actually who used to say, or who maybe he still says it, that he never worked a single day in his life because it was all, and I feel the same way, and that's been a real privilege. So.
Oh, well, I think your humility and your modesty are shining forth here. I think, I really attribute your success also to your perseverance, your hard work, your ability to network, your brilliance, and just your passion. And I think the advice you've given to be persistent and to knock on doors and find mentors is really great advice. And so many of us at Mayo credit Dr. Fry with whatever modicum of success we've had. Bob has played a big role, and truly one of the giants as well. Well, I think our audience can see why you are now part of the legends that the Mayo Clinic Proceedings has interviewed. And we just are grateful for the years you gave us in Rochester and your collaboration as a Mayo alumnus. Once you're part of the Mayo family, you're always part of the Mayo family. So, we still think of you as a Mayo physician on loan to the NIH and to the U.S. government. And, thank you for giving us time this morning to share your story and tell us about your exciting career. And we look forward to watching what you continue to do and to see what you're doing with the intramural program for community and public health. It'll be exciting to see, and look forward to seeing you present at the national stage as well. Thanks again this morning.
Thank you so much, Dr. Wright. It's been a privilege and an honor. Thank you.
Thank you, Dr. Roger.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.